Welcome all of you to this live program at Orthopedic Principles. Today our guest of honor is Professor Young Lee Moon from Seoul, South Korea. Professor Moon is a director at the YM Orthopedic Hospital in Seoul, South Korea. He's also a professor at the Chosun University Hospital since 2010. Professor Moon has been the president of the Korean Shoulder and Elbow Society during 2017 to 2018. Professor Moon is the vice chair of the Medical 3D Application Work Group, where he's performing the standardization of medical 3D applications. Professor Moon is a directorial committee member of Korean Stem Cell and Regenerative Medicine Society, as well as the Korean Sports Medicine Society. So today it's my great honor to introduce you to Professor Young Lee Moon from Seoul, South Korea. Over to you, Professor.
Thank you. I'm Moon from Korea, and today my talk is about the issue of traumatic shoulder instability. Shoulder is both stable and mobile and flexible joint. It is clearly dependent on the inferior glenohumeral ligament for stabilizing and proper mobility. Additionally, it is working together with scapula for obtaining full range of motion. My talk is divided into three parts: types, diagnosis, and how to treat those. There are three main types of shoulder instability, especially for anterior instability. The one is soft Bankart, the other is bony Bankart. Final one would be specific Hegel lesion. Let's see the IGA chair and the instability. If IGA chair is unstable or torn, so-called Bankart lesion, patient shoulder is easily going to dislocate anterior way. If I say more specifically, anterior and inferior way. When patient is try to performing elbow position, abduction, and external rotation position, patient easily going to the instability or complain the pain or instability. Another issue is heel sachs lesion. It posterior superior part of the humeral head. As you can see, posterior and superior part of the humerus, there is defect, and it is kind of cause of engaged heel sachs lesion, resulting more significant unstable shoulder. How to detect those conditions? We can define the patient condition by physical test, MR, and/or MR-sonogram, and CAT scan. Let's see the patient, the instability. Patient feel discomfort when we raise up the patient arm in spine position. If we push down, patient feel comfortable. If we try to raise up the patient arm front way, patient feel discomfort or apprehension or pain. We can detect patient with a sit-down position too. Feel comfortable and feel apprehension with pushing anteriorly, feeling comfortable, push back the arm posterior way. Relocation and apprehension simultaneously. Another issue is bony Bankart lesion on a bony apprehension test. Usually patient feel discomfort when they are 90 degrees of abduction, but this kind of clearly unstable patient, if patient has a bony defect, significant bone defect in the anterior part of the glenoid, the patient will complain with a tiny amount of abduction, only with even 20 degree or 30 degree of abducted condition, patient feel discomfort or feeling of apprehension or feeling of instability or pain. And if we want to detect amount of instability, we can apply anterior draw test, shifting test. Then we can define amount of instability of and integrity of IJHL pair. Some patient has also capsular laxity, so we can detect inferior translation test with the adopted condition or abducted condition for watching IJ chair or rotator intervals, something the laxity and posterior instability too. It's not only common in the lady, even the young man also have a posterior, anterior and posterior instability and feeling of discomfort. And when we apply this one as a inferior the translation, patient feeling discomfort. So when we decide to the procedure for stability procedure, we need to checking the ligament laxity for obtain amount of capsular tightness. So whether patient has some skin tug or inferior translation and elbow recurvatum and yes, we need to check other joint too. MP hyperextension and some forearm distance. Yes, we can check the radiologic study for confirming or evaluating patient condition more clear way. We can check MR and or MR arthrogram for watching patient ligament integrity inside. Yes, from the sagittal view to axial view, watching capacity of the joint and the clear the gap of the ligament. Yes, our goal of surgery will be obtain functional joint with mobile and stable joint. During the surgery, we can fully sedate it and we can obtain proper the ligament, the condition, integrity. If patient is alert, the muscle is sometimes obstacle for watching and evaluating patient the condition clearly. But if patient is sedated, we can watch out clear condition of the ligament integrity and static the stabilizer clear way. Yes, load and shift test and drive through sign for watching the gap in between glenoid and humeral head. The first surgery for soft Bankart repair, we apply the repair with arthroscopic way. The arthroscopic stabilization of the ligament of anterior and inferior glenohumeral ligament. Major principle is ligament attachment and obtain proper amount of glenoid depth for containing glenoid, the humeral head into glenoid, such so-called bumper effect. Usually watching from the posterior portal, and the working portal would be anterior two portals. And detaching the labrum from the a little the unstable ligament. Then having a point, pilot hole, usually more stay in the articular side or obtain more advancement. And having a suture, we need to obtain as much as capsular component simultaneously. And tie down. I prefer the tennis slider for obtain more very simple and easy sliding the technique, and we take down the capsule. And repairing capsule with more advancement of capsule from inferior to upper, the upper the glenoid. I usually utilizing 3 or 4 anchors from 3 o'clock position to 7 o'clock position for keeping secure fixation. I try to more over tightening rather than the under tightening or normal tightening, because patient is a little kind of uh, this kind of unstable patient is susceptible for redislocate again and again. That's why I try to more over tightening for obtaining the proper uh, proprioception mechanism. The another issue is bony Bankart lesion. Bony Bankart is so common case in young patient. So this is 21-year-old male with revision bony Bankart. As I told you before, 1 posterior portal, 2 anterior portal for working and repairing process. As you can see here, there is the previous stitch, and I put the anchor. I eliminate this suture material, and yeah, as you can see, here is the gap in between glenoid and the it's a previous stitch also. Then I repairing stitches. First stitch is most important for obtaining proper position. After that, additional stitches are, yes, quite supportive. Even though patient reveal the feeling secure under the arthroscopic view, or 2 or 3 stitches enough, but I usually add 2 more stitches for having something the supportive, not to having something. Sometimes this kind of the stitch is easily going to slip. That's why I add a preventive, the additional stitches. This is 37-year-old male. It's bleeding because of fracture. Now you can see the bone. Yes, this is a fracture. So top fracture. Yes, here is the bone fracture. not same as soft Bankart. We can figure out, yes, this kind of on the top, the bone blocks. And then we repairing and reducing this fracture. I prefer sliding knot rather than non-sliding knot to obtain proper tension. Usually, after one anchor, then we are feeling more secure. And next anchor procedure is more the easy process. But first anchor is most important for obtain proper reduction of the fracture. As you know, this kind of bony Bankart lesion is both fracture reduction and the labral fixation process simultaneously. And I add additional stitches for not having slippage again. Yes, I nearly flipping like bumper, more deep bumper than the normal size. Because as time goes by, it is going to shallow and shallow. Because patient during the rehab process, patient is prone to more anterior translation. It makes more shallow bumper as normal the condition. That's why I try to having more the deeper bumper than anatomy the condition. This is 46-year-old male. I'm not sure about the other countries' condition, but Korean, the middle-aged person, they like drink alcohol, then they lose their control, then they have this kind of big bony Bankart. As you can see here, here's a defect. So for penetrating bony defect and bony Bankart, I utilize the one-time use suture hook. If I utilize reusable suture hook, we cannot penetrate bone the region clearly. That's why I utilize just one-time use the suture hook or obtain or a sharp hook, the knife, the metal hook can penetrate this kind of very spongy bone conveniently. Another issue is bony Bankart. The bony Bankart is, if it is more than 25%, we prepare bony procedure, but less than 25%, we can performing with the repairing of bony Bankart, the bony Bankart repair or open repair. If patient has a component of the MDI the issue also, I prefer utilizing open Bankart repair in case of very unstable shoulder, such as lady or the young generation or the contact athlete. So if patient has a multidirectional instability with contact sports with large bone defect, I performing open repair. During open repair, I apply the capsular shift surgery in between middle glenohumeral ligament and inferior glenohumeral ligament. So open the capsule. and watch the bone defect repairing with the anchor, the labrum repair, and shrinking the tissue is so-called better suture. This area is shrink as this size. So we obtain proper capsular shrinkage or obtain the capsular instability. Also, we can obtain proper amount of proprioception, the sense, and performing capsular shift, the capsular incision in between MJHL and IJHL. And proper tension is this index finger. This index, if we put index finger in between, at the part of axillary porch, then this amount is proper. If too shallow, patient is complaining long period of stiffness, but it is too lax, the patient easily going back to instability again. Yes, this is finally we did this tissue into this capsule into the 1 centimeter of remnant of the other capsules. So this in between this incision and humerus attachment is 1 centimeter usually. That is enough the remnant for repairing the medial and lateral original tendon ligament and capsule there. So this from here to the humeral attachment, so 1 centimeter in between the capsular cut place. Finally, we apply the subscapularis repair. Yes, rehabilitation is quite similar as other procedure. You usually return back to sports at 6 months, and full motion is 3 months. That's usual program as the shoulder procedure. This is the incision site. Another issue is Hegel lesion. Hegel lesion is cutting the injury at the humeral side, not the glenoid side injury. Let's see the MRI. The MRI reviews this kind of something high signal at the humeral side. So by the patient expression of this Hegel lesion is they are complaining the pain significantly. As you know, shoulder dislocated patient after the reduction of the dislocation, patient complaints clearly disappear. But even after in Hegel lesion, even after the reduction, the patient complaints clearly significant. So you should suspect whether the patient has a Hegel lesion or not, and especially in the patient is middle-aged person. Young patient, the tear is usually happen around the glenoid Bankart region, but or middle-aged person or lady, if the patient complain the pain even after shoulder reduction properly, so we should suspect whether there is the Hegel lesion or not. As you can see here, there is a defect. Here is humerus, and here is the ligament detachment at humeral side, humeral head detachment. So we're repairing this one. Put the anchor from the around inferior glenohumeral ligament area. Sometimes patients review simultaneous tear of the rotator cuff tear too. This patient has some kind of another something gradual, the generalized problem. Also, the Hegel lesion is simultaneously then I repair this one. After that, patient will clear the relief of symptoms and obtain full range of motion. Another issue is heel socks lesion. Commonly, you don't need to heel socks repair clearly, but only in case of engaged heel socks lesion, we need to repair. So repairing the infraspinatus area, and we augmented with this suture anchor. So this so-called remplissage surgery. This kind of engaged heel socks lesion, even after the repair, then we need to apply the fixation of tenodesis of infraspinatus into the heel socks lesion. Even after this Bankart repair, the patient complain and the feeling of the dislocate again and again. We need to repairing heel socks lesion again. It is a little more common in the lady or some very wrong a little bit the latent reduction of the rotator cuff and the shoulder dislocation. So this is the surgery after the remplissage. We have tenodesis of infraspinatus, then patient obtain proper stability from anterior to posterior, and patient obtain full range of motion. Yes, anterior and posterior tenodesis, patient obtain full range of motion. Indication of remplissage surgery would be small glenoid bone loss and large heel socks lesion. Additionally, capsular laxity patient obtain good result after this remplissage surgery. The final issue would be large bone defect. In such a case, there is no choice, only the bony procedure with the sling effect is required. So-called Latajet or bony augmentation or the bone graft for obtain proper the stability in contact sports players. So rugby player or the soccer player, if their patient shoulder is dislocated again and again, the Latajet procedure is the treatment of choice. The protocol is quite uniform. 3 to 6 weeks of immobilization and the standard sling and abduction, and we can allow full range of motion 3 months after the surgery, and they can join in contact sports 6 months after the surgery. In conclusion, we need to define pathology clearly, whether it is capsule or ligament and bone defect. So how much and how slack, that's the major issue for decision making the issue. And the secure fixation or compensation by some sling effect or bone augmentation. And if we performing the surgery the perfect way, then we can provide personalized rehab protocol for obtain good result. Thank you.
Thank you very much, Professor. Professor, you can stop sharing.
Yes.
Yeah. You can close the PPT.
Yes, I close the PPT.
Are you sure? Because we can still see the screen here.
Oh, really?
Yeah.
Oh, I'm done.
Okay, no worries, Professor. Professor, thank you for this comprehensive presentation. And let's take a few questions. Professor, how do you approach a Hagel lesion? Is it open or arthroscopy?
I always arthroscopic the procedure. At the beginning, And when I was junior doctor, I performing the open procedure from under the subscapularis, but now I always open I always utilizing arthroscopic procedure.
And how is your recurrence rate with arthroscopic procedures? What is your recurrence rate?
It is less than 3%. So only high recurrence, something highly recurrence, some dangerous patient would be epilepsy patient. So I warning the patient or patient attendant or patient father and mother, your son and you are going back to recurrency if you do not control your epilepsy. If not, but usually, yes, patient is okay. Yes, less than 33%.
Thank you, Professor. Professor, we are also joined by Dr. Srivan Desari. He's an orthopedic surgeon from Warangal, India.
Hello, sir.
You already know him. Srivan, welcome to the show and your questions to Professor Moon, please.
Good evening, Professor. Hope you are doing well. What is your opinion regarding this age-specific management of open Bankart repair versus arthroscopic? Do you manage the same way the first episode or the recurrent episodes?
Say it again, please.
In a young patient, do you manage operatively or conservatively? And in the elderly patient, you operate conservatively or
Yes.
surgically?
It is clearly depend on the age. Young patients less than early 20, I do not hesitate performing arthroscopic repair, even it is first time dislocator. But if patient is late to 20, I'm thinking over. After the first time dislocate, I'm thinking over performing the surgery or not. If he is somewhat contact sports player, maybe I'm performing the surgery first, arthroscopic surgery first. If his condition is recur again, maybe I am performing the open Bankart repair or Lataji.
My next question is, at your center, I have seen MRI orthogram being prepared with distilled water. Can you please explain regarding this, sir?
Yes, if patient is dislocated at the day of if patient is visiting my clinic at the day of the dislocation or just one day before or the next day of the dislocation, maybe I am not performing the MRI sonogram, but if the patient spend more than 7 days, I performing MRI sonogram for watching even tiny amount of the labral defect.
Any more questions, Srivan?
Sir, that's it, sir.
Okay, we are also, Professor, thank you so much. We are also joined by Loy Al-Khatib is an orthopedic and sports surgeon based in Dubai. Loy, welcome to the show. Loy is actually very busy. He told me he was in the clinic. Loy, are you available? I think Loy is, he told me he was very busy in the operating room and clinic. He was alternating. No worries, Professor. Professor, I think, Professor, I think that's all the questions that we have for this session. Thank you for this wonderful presentation.
Thank you.
Thank you very much, Professor.
Yes,
I'm sure
it's a very nice to you. Thank you.
Everyone.
Thank you.
Thank you so much.
Thank
Bye.
you, Professor.
Okay.
Thank you, sir.